Now we will discuss about the metabolic response to surgery and critical illness. Starvation and protein loss. Main energy reserve is fat. Main protein reserve is skeletal muscle. Skeletal muscle is main protein reserve and fat is main energy reserve. Protein breakdown. 1 gram of nitrogen in urine is equal to breakdown of 36 gram lean tissue. Normal protein turnover. Normal protein turnover is 150 to 200 grams per day. Normal intake is 70 to 100 gram per day. 14 gram nitrogen excreted daily. Starvation adaptation. Nitrogen loss decreases. Survival possible for 50-60 days. When nitrogen loss decreases, chances of survival increases for 50 to 60 days. For example, in hunger strikers. Critical illness in sepsis or trauma. Sepsis is response of body against infection, and trauma is some kind of accident or some situation. Adaptation fail leads to autocannibalism. Nitrogen loss 10 to 20 gram per day, 500 gram lean tissue day. Loss of 30 to 40% body protein mass leads to, when there is loss of 30 to 40% body protein mass, then survival is unlikely. Body composition changes in the critical illness. In severe sepsis and trauma, immediate weight gain due to 6 to 10 liter extracellular water expansion. Despite nutrition, 15% protein loss in 10 days. 15% protein loss in the 10 days. Elective surgery. Weight and nitrogen balance can be maintained with epidural analgesia. Blocks stress response. Early oral enteral feeding. Careful fluid balance management. So, body composition changes in critical illness. Now we will discuss about the avoidable factors that worsen injury response. Key compounding factors are hemorrhage and volume loss. Hemorrhage is basically loss of blood from body during trauma. Hypothermia, tissue edema, tissue underperfusion, and starvation, including pre-op fasting. So these are avoidable factors that worsen injury response. Immobility, sepsis and medical complications. So these are avoidable factors that worsens tissue injury. Physiological response, volume loss, baroreceptors and atrial receptors. They stimulate aldosterone and ADH release. Effects of volume loss, sodium and water retention. That leads to oliguria or decreased urine output. Oliguria is very low urine output. So, and exacerbated by saline-rich fluids. That leads to peripheral and visceral edema. Visceral edema leads to delayed gastric emptying and prolonged hospital stay. Hypothermia, increased catecholamines and adrenal steroids. It leads to 2 to 3 times higher cardiac arrhythmias. Cardiac arrhythmia is abnormal heart contractions. Increased catabolism, breakdown of proteins. Normothermia maintenance, it reduces infections, bleedings, and transfusion needs. Tissue edema is caused by systemic inflammation. That leads to capillary leak and results in impaired oxygen diffusion, renal dysfunction, and cellular hypoxia. Starvation, brain requires 100 gram of glucose per day. Sources of this glucose is in first 24 hours Glycogen is main source of glucose. Later, gluconeogenesis, amino acids, glycerol, and lactate. These are sources of glucose later. Adaptation. Ketone bodies replace glucose for brain. So for brain, ketone bodies replace glucose. IV dextrose 80 gram per day. Protein sparing effect. Modern fasting guidelines. Clear fluid allowed up to 2 hours pre-op. Carb drinks reduce anxiety and insulin resistance. Immobility. What it does? Immobility causes muscle wasting due to impaired protein synthesis. Immobility causes muscle wasting due to impaired protein synthesis. So prevention is early mobilization and rehabilitation programs. So these prevent muscle wasting. Now we will discuss about enhanced recovery after surgery or ERAS program. It is evidence-based multimodal approach to reduce stress response. Principles of ERAS: minimal access surgery, that is laparoscopic surgery, blockade of pain stress pathways, epidural, spinal, mount catheters, minimal fasting, and early mobilization. These three are main principles of enhanced recovery after surgery or ERAS. One is minimal access surgery, that is laparoscopic procedure, and blockade of pain stress pathways, minimal fasting, and early mobilization. Benefits of ERAS are 30 to 50% shorter hospital stay. Benefits are 30 to 50% shorter hospital stay, reduced complication and healthcare costs. Adjuncts: beta blockers, improved survival. Epidural analgesia for open surgery, not laparoscopy. Patient controlled analgesia, spinal diamorphine, and IV lidocaine. Now we will discuss about the key medical terms used. Catabolism. What is catabolism? Breakdown of complex molecules and that release energy release. Anabolism. Building up of complex molecule, tissue growth. Oliguria. Oliguria is low urine output. Aldosterone, hormone that conserves sodium and water. ADH, antidiuretic hormone. ADH promotes water retention. Hypothermia, abnormally low body temperature. Hypothermia is very low body temperature. Oedema, fluid accumulation in the tissues. Gluconeogenesis, production of glucose from non-carbohydrate sources. Ketone bodies, alternative energy source for brain during starvation. Rehabilitation, exercise nutrition program before surgery to improve recovery. ERAS. What is ERAS? Enhanced recovery after surgery. Enhanced recovery after surgery. Protocols to reduce surgical stress and improve outcomes. So we have already discussed about them. We will discuss summary of all this. Starvation versus critical illness. Starvation triggers adaptive protein sparing mechanism, but in sepsis and trauma, these fail, leading to severe protein loss. Body composition. Critical illness causes fluid retention and protein breakdown. Elective surgery can avoid this with proper management. Avoidable factors: hypothermia, edema, starvation, immobility, and poor fluid management. Worsen outcomes. ERAS protocols. ERAS is a series of modern protocols that are very helpful. Modern multimodal strategies. These strategies are laparoscopy, early feeding, and pain control. And mobilization. It significantly improves recovery, reduce hospital stay, and lower complications.